Thanks everyone for being here today. I'm going to discuss the TOPS device in lumbar facet arthroplasty, which is a motion preservation alternative to fusion surgery. My name is Jacob Joseph. I'm a neurosurgeon at the University of Michigan. So just to understand the biomechanics of the spine, when you think about the spine, each motion segment, which is basically one joint between two levels, say L4 and L5. It's an interaction between multiple areas. The disc and the facets are probably the two most important areas, and both those contribute to the motion in the spine. The disc functions to really act as a shock absorber between two levels and really handles the load in the spine. The facets are what provide resistance to shear motion and really what allow us to move the way that we all do with flexion, extension, rotation, etc. And the quality of the facet joints are really what determine the range and quality of our motion. So in degenerative spondylolisthesis, which is a very common condition, that results from incompetence of the facet joints in the back. And when those facet joints become incompetent, it can lead to one vertebral body slipping forwards or backwards, but typically forwards over the lower vertebral body. With that, arthritis can start spinal stenosis as well. That stenosis provides compression of the nerves. And that compression of the nerves can lead to irritation and pain, particularly pain down the legs or into the buttocks on both sides. Now, this problem is most common at L4-5, and by far the most common level, much more so than L5-S1, and more so than the lumbar levels higher than that. And this is definitely a arthritic condition and becomes more and more common as people get older. The classic treatment for this problem is a fusion surgery. And so there's been a huge number of patients that undergo fusion for this problem, which can be the right option for a number of patients where, you go in, you put in rods and screws and usually cages, and then go in and open up space around the nerves and do a fusion surgery. So that's the classic sort of treatment for this problem. And that's where TOPS comes into the picture. TOPS is a new device. It was FDA approved in the US last year. It has been kind of in use in other countries and in the trial process for much longer than that. And this is one of the first new devices that's been able to be utilized for lumbar spondylolisthesis. And it's been really exciting to see its onset and the potential for it. So the TOP system is indicated for people over the age of 35 with what's considered a grade 1 slip or spondylolisthesis in the lumbar spine, and typically from L3 to L5. The FDA approval is a really high bar to get for any medical device. And the trial process was very important, and I just want to touch on that trial process because it was pretty extensive as to how this device eventually got approved through the US FDA. It was a study that involved 300 people, a little over 300 people, of which about 200 underwent TOPS and about 100 underwent the TLIF, or transforaminal lumbar interbody fusion, which I would say is had been the standard workhorse for this sort of problem. And then those patients were evaluated annually up to 5 years, but at intervals along the way. And you can see the criteria for the study and which patients were involved in it. But basically that over 35 and predominant leg symptoms, meaning that these patients all typically have some sort of spinal stenosis. Notably, did exclude patients who were considered to be significantly obese, and patients who had multiple levels of problems in their spine, and was pretty limited from that standpoint, but really trying to target this exact group of patients with the one level slip in their spines. What was looked at to determine what surgery was better was a whole multitude of different things, and eventually developing what's called a composite clinical success score, in which basically the surgery had to be pretty close to perfect to be able to be considered a success. And importantly, that means no reoperations, no need for any further injections, a significant reduction in the ODI, which is one of the scales that we use to grade success in lumbar spine surgery. No new neurologic problems, no device failures, and then no fusion failure for the fusion group. So when we look at the results of this study, that overall composite clinical success score was much more common in the TOPS group as opposed to the fusion group. And even when you exclude the fusion success problems, it was still pretty notable difference of 78% of TOPS patients achieving full clinical success and only 53% in the fusion group achieving clinical success. And so the FDA did conclude that TOPS was in fact superior to lumbar fusion for this subset of patients, which was a major milestone in not only for TOPS but really for spine surgery as a whole, because it's the first time we've really had a really notable new treatment option, and that's really kind of what got me excited. At the University of Michigan, we were part of the FDA study, but we really started getting going with this procedure after the FDA approval, because I think that was really when we could truly offer this to patients in a way that was an exciting new opportunity, new offering that we just did not have before last year. Looking a little bit more carefully at the data, you can see that the clinical success score again is a composite of all these different measures, but if you look at each individual one, the success rates are really quite high and almost to a T were better than with fusion surgery. Why TOPS is important as a spine surgeon is sometimes maybe a little bit different than you might think. I mean, the motion preservation is a really attractive portion of this, which allows, the L4-5, say, if we're doing a fusion surgery, we're taking out the motion in that segment in order to treat the problem. And that does work in the vast majority of cases, but it does mean that we're reducing flexibility in order to achieve success. With the TOPS device, we can do a very similar operation, but not have to sacrifice the motion. And we can see on these pictures here that the motion actually improves a little bit with time after surgery. A lot of that's because of as the muscles heal, it allows for a little bit of motion to come back in. But we can see clearly on the post-op x-rays that the motion is preserved. So is at the surgical level, which is really exciting because it does prove the point of what this device is supposed to do. Now, that motion, again, is important from a flexibility standpoint, but it's even more important from kind of the dreaded complication of fusion surgery, which is adjacent level disease, meaning that if you have a surgery at L4-5, for example, then you might develop some new stenosis at L3-4. The reasoning for that is because we're taking out the motion at the level below and it puts more stress on the level above. And the hope with things like the TOPS device is that because it is not taking away the motion, that there should be less of a chance for adjacent level problems. And that's really, from a spine surgeon standpoint, that's the thing that's really exciting about this, is that hopefully we're doing a one and done operation that we don't ever have to go back in.
For those that are on the webinar that may not know exactly what they're seeing here, could you just explain this lateral view and really what they're seeing?
Absolutely. So yeah, this is a lateral view showing an X-ray of the lumbar spine showing. I don't know if you can see my cursor there, but this is L4 right here, and this is L5. And when we follow the spine down, we see that if we follow the spinal line down, there's a step off right here. And so this is the slip between L4 here and L5 here. The yellow lines are in L5. And so that's where the problem is that slip there. And this is the surgery, post-op, where we put in screws at L4 and screws at L5, and then this back here is where the device sits, and that's what allows us to keep that motion in. And so what we can see, unfortunately, the animation is not working, I don't think, on this, but is that it's providing that same gap here and allowing that motion to still exist after the device is in, which is again is unique to this compared to fusion surgery. Same concept here. What we can see in these x-rays is that basically you can see the side-to-side motion as well. So bending to each side is possible with this device, in addition to flexion, extension, and rotation. So, and again, that motion does persist over time and is actually better than it was before surgery, which is interesting because that arthritis really does limit motion at baseline.
So for the people on the webinar that may not, once again, understand what they're seeing, this is from the front of the patient's body. It's an X-ray of the front, where the previous slides were from the side, a lateral view. This is what's called an AP, from the interior or the front view of the spine. So actually same patient, right? So this is the same patient, same device, same level. Just want, I don't know if you want to expound upon that, but just want to make sure the people that are on the webinar understand what they're seeing.
Absolutely, yeah. So yeah, that previous slide I'll show here is the view from the side, showing that device. This is the view from the front, and again, you can see 4 screws that are put in during the surgery, and then there's the TOPS device, which basically sits in all 4 screw heads. and it's secured in place there. And then again, this is where that motion occurs, is through this portion of the device right here. And this just kind of, again, showing that motion that exists there. So this was actually, I believe, the second patient that we did outside of the trial process, through, kind of standard care. A 66-year-old gentleman who had chronic back pain, but also had pain, numbness, weakness in both of his legs when trying to stand and walk. He was an avid amateur hockey player, but was just unable to play due to his significant symptoms. And then this is a lateral view, a sagittal view of the MRI, showing this is L4 here and this is L5, and there's a slip, a spondylolisthesis at L4-5, and you can see the bundle of nerves coming down here, and it's really getting pinched at that L4-5 level, and that's what was contributing to most of his symptoms. We had a discussion with him about surgical option, basically talking about fusion versus the TOPS device, and went through the risks and benefits of both, and ultimately he was really keen on the TOPS device because of his desire to ultimately be able to play hockey into the future. And that really excited him because he was a very active person. So we did the surgery, which went really well, thankfully. And these are his post-op. This is post-op CT. Again, showing the front view and the side view side by side here. You can see the 4 screws that are put in during surgery, and then the device that sits in the 4 screws. And he did incredibly well. He felt great in the hospital, was discharged home, and then I saw him back at the 6-week checkup, and he was just raring to go. Really, just his major question was, when can you resume playing hockey? And then he had admitted to me that he was already skating at that time. He just wanted to be able to actually play hockey again, and no reason to hold him back at that point. And so we did clear him to go back and do basically anything he wanted to do. And I think he's been a shining example of what this device can do. We've been really excited about it. A lot of patients are really excited about it. So my colleagues are excited about this device because, again, it's really the first time in spine surgery we've had an alternative to fusion for this exact problem, and so it's been really exciting to see it get going. So I'll stop there. This is my name, my contact information. I think maybe we can take some questions, Jeff.
Yeah, yeah. I'll start though on that previous slide. So if you'd have fused that level with this active of a patient at 6 weeks, normally would this patient be able to resume hockey or skating at 6 weeks?
No, that would not be standard to do at that point. With the successful fusion at about a year, we can consider going back to contact sports, but it's with some hesitance, I would say. But yeah, it would really be more like 12 months that we could really consider that, and that's only if the fusion completely heals in, which is a big if.
Yeah, and we'll see on the Q&A here whether we get one of these questions, but we typically get several questions around what to expect post-op as far as recovery versus fusion. And so I thought I would ask that question. That's an amazing case, especially for 6 weeks post-op to be. I know I know patients feel really well at that point, but to resume hockey, and it's pretty impressive.
Yeah. Yeah.
Really impressive. Yeah, if you want to go to the final slide. So we're going to open it up to Q&A now. How about we start off with an easy one? I've had a fusion at L4, L5 about 5 years ago, and my MRI now shows a stenosis at L3, L4. Am I a candidate for TOPS?
Yes, so the answer is yes. There are methods by which we can do an adjacent level problem. And so if you've had a previous surgery at L4-5, it would be a little bit dependent on your imaging and your anatomy, but typically that is possible to basically remove the hardware at L4-5 and then replace it in such a way that we can do the TOPS device at L3-4, and your L4-5 would remain fused. So it is possible.
Very good. Let's see. This one is about, well, can an overweight patient still have this surgery?
The answer is certainly yes. In the trial process, there was a BMI cutoff of 40 for the trial, but that was through the FDA approval process. Within now that it's FDA approved, we can are able to do things a little bit more at surgeon discretion, with consultation with the patient, of course. Certainly, lower weight is better from a just less strain on the device itself. Well, we've certainly, depending on your weight, it's certainly possible. We've certainly done it in patients with elevated BMIs that are, considered overweight or obese, with success. So it's definitely possible.
This particular person says, I've had 3 back surgeries, one in 2000, one in 2013, and one in 2015. Doesn't say what type of back surgery, so that's open for speculation. Also, I've had many steroid injections over the last 8 to 10 years. Am I a candidate for TOPS?
Yes, so from a steroid injection, that really would not be a problem at all. For the back surgeries, it would depend a little bit on what type of back surgery. So if you've had previous fusion operations, that again, it would be just dependent on what types of fusions they were. If you've had laminectomies in the past, that wouldn't really be a problem. We can certainly do TOPS in the setting of a previous laminectomy. Again, with fusion, like that the previous patient had asked about, there's certain situations where you can do it. So it depend a little bit on the types of back surgeries, but just for having a back surgery, that by itself not a problem.
Good. Here's one. I'm 67 years old and have pain and numbness and tingling down both legs, but particularly the left leg, and stabbing, stinging, and burning in my left hip, and L4, L5 on left side lumbar consistently. So I'm assuming that's part of the burning. So based on that, those symptoms, what is your perspective on whether this patient would be applicable for TOPS?
Yeah, based on those symptoms, I think that's a pretty classic constellation of symptoms for a patient that might have a degenerative spondylolisthesis or degenerative slip in the spine. Those symptoms, again, would be pretty classic for the types of patients that might benefit from this surgery. Again, it would depend a little bit on your imaging and your anatomy and things like that, but those symptoms are pretty classic for what we're trying to treat, and very similar to actually that patient that I presented in terms of the types of symptoms that he was having before surgery.
And actually got a follow-up kind of active. These are active questions that are. I've this patient have had 3 laminectomies: L3, L4, L4, L5, and S1. Um, so all of that still sounds like, I mean, could possibly
Yeah.
be TOPS. Yeah,
Certainly, yeah, certainly could be a candidate for TOPS.
yeah, absolutely. Here's one about how long is the surgery and what's the typical hospital stay and then recovery. So kind of the full spectrum
Yeah.
of
So typically, hospital stay is one night. So surgery and home the day after surgery. Because of the type of open, but I'd use a technique with a robot to be able to put the screws in. Surgery itself takes about 2.5 hours, typically around 2.5 hours of surgical time. You can typically go home the day after surgery. We sometimes do leave a drain in that comes out 2 or 3 days after surgery. And then for that 6 week period, it's primarily for actually just the skin and soft tissue to heal, the muscles to heal. We have people take it pretty easy for the 6 weeks, up and walking the same day of surgery, able to, get around and take care of themselves. But, ask people to keep it pretty low key for about 6 weeks. And then at 6 weeks, I'll see people in the office and make sure they're doing okay and get some x-rays and make sure we're happy. And then usually at that point, we're kind of releasing people, basically do whatever they would like to do, including hockey like that.
including full contact sports.
Yeah, exactly. Yeah. So yeah, generally a pretty quick turnaround and like we talked about earlier, pretty dramatic difference compared to fusion surgery.
Yeah. Another question. We got a lot of good questions here. I'm 80 years old and just had an RFA, but still have a lot of pain. Am I applicable for TOPS?
Yeah, so RFAs typically are to treat facet pain, and that can be a part of the problem with a spondylolisthesis. If the RFA did not do enough to treat the pain, then you could potentially be a surgical candidate for TOPS. The failure of the RFA does not mean that you would not be a candidate.
Another good one here. So 66-year-old male, very active, skiing, boating, etc. MRI has confirmed issues at L5. 2 X-ray guided injections help the back stability and pain, but my right foot is still tingling. Stenosis and spondy confirmed. Am I applicable for TOPS?
Yeah, that sounds like again another pretty classic story. And if you have a confirmed stenosis and spondylolisthesis at L4-5, then I would say absolutely. It seems like you would be a good candidate for TOPS. Yeah, it does sound like that way.
Where's this other question? Oh, will this device work with someone with autoimmune disease?
It's a great question. Autoimmune disease there's multiple manifestations of autoimmune disease. The short answer is yes, you would still be a candidate for it. The caveat is that we would certainly want to check your bone strength and make sure your bones were strong enough to handle a device like this. And if they weren't, then we could, treat you with some bone strengthening medications and things like that prior to surgery. But yeah, certainly, patients with like things like rheumatoid arthritis, lupus, things like that, that would not preclude you from being a candidate for this device. And in some ways, it might be better than a fusion operation for those sort of conditions.
Here's an interesting question. I'll abbreviate it a little bit, but it's really asking about the utilization of pre-planning software, robotics, surgical navigation. You might want to speak specifically of what you really use with TOPS and why you like that and how it benefits you in your hands, maybe versus doing the procedure freehand without the assist of that. But there's a really interesting question about just in the range of those types of technologies.
Yeah, absolutely. It's one of the exciting parts of, new technology. And so I currently do use pre-planning software and a robot to place the screws minimally invasively and then make a relatively small open incision to place the device itself, the TOPS device itself. We've had really good success with that. That's kind of getting our operative times down, but also getting more accurate placement of the device itself. We really do want to place the device kind of perfectly in the spine in order to maximize the amount of motion that every patient's getting out of it and also increase the chance of success. And so, yeah, it's a very exciting area, with a new device like this to kind of find the best way of utilizing it. And I think that's one of them for sure.
These have all been great questions tonight. We're almost out of time, so we'll go with one more question here. I've had a 4551 fusion 10 years ago. Am I a candidate for TOPS?
Yes, even if it's been a two-level fusion from L4 to S1 in the past, we would still be able to place the TOPS device at the L3-4 level. Again, it would depend on the anatomy and how the previous fusion was done, etc. But yes, that typically would not be much of a problem.
We'll squeeze one more in. Does kyphoplasty preclude me from being a candidate for the surgery?
No, it would not. Again, the caveat there is that if the kyphoplasty was done for because you had a fracture due to like things like osteoporosis or poor bone strength in the past, then we would have to really double check and make sure that your bones were strong enough to handle the TOPS device. But again, that can be true with medications if need be and optimized so that you would be able to be a candidate for the device. So yeah, having the cement from the kyphoplasty itself would not be a problem.
Great. Look at that, right on time. Dr. Joseph, thank you for your time tonight. Very educational. You did a great job. Participants, thank you for attending. These were great questions. I'll remind everyone that we do this every 2 weeks. We invite prominent surgeons from across the country that are currently utilizing the TOPS device, and they answer your questions for you, and you get to know them a little bit more personally and about their practices and their perspective on the device. And thank you for joining us. Thank you for being interested in searching out solutions and taking responsibility for your care or the care for your loved ones. But once again, thank you for your attendance tonight. Once again, Dr. Joseph, thank you very much. We really appreciate it. Everyone have a great evening. Take care.
Thank you guys.